final type of shock that I will be discussing is obstructive shock. This can be found three ways: tension pneumothorax, cardiac tamponade, or pulmonary embolus. This is basically an obstruction which is preventing adequate blood flow. The problem can be found in the right heart or the lungs, and this will be seen by a decreased flow to the left heart. Cardiac tamponade is caused by an accumulation of fluid in the pericardial sac, the most common cause being infectious pericarditis, or also caused by surgery or trauma. This fluid causes excess pressure on the right ventricle and therefore decreases venous return to the heart. With your patient assessment, you're going to see dyspnea, tachycardia, and poor perfusion as evidenced by cyanosis and slow capillary refill. Hypotension, quiet heart sounds, friction rub, distended jugular vein, these will all be seen as well. Tachypnea, anxiety or restlessness, chest pain, and pulsus paradoxus may also be found in your patient assessment. Electrocardiogram and echocardiograms are used to diagnose obstructive shock. A Swan-Ganz catheter will be placed to monitor hemodynamics. As pericardial pressure increases, the cardiac output worsens. A sign of cardiac tamponade will be an increased CVP combined with a decreased blood pressure. All values past the right heart should be decreased due to the right heart's inability to pump blood effectively. This includes the SVR. Because this is an emergent condition, the first thing that must be done is a pericardiocentesis. This is done to drain the fluid and relieve that pressure which is surrounding the heart. Secondary treatments include vasopressors and inotropic drugs like dopamine and dobutamine to increase heart contractility and to increase the blood pressure. Fluid restoration with colloids, oxygen therapy, which supplies the tissues with supplemental oxygen, which is decreasing the work of the heart and what it's having to do. The Swan-Ganz is also important at this point to monitor pressures to ensure that the fluid does not reaccumulate. Because of the tachypnea, one would assume that the patients would have blood gas with a low CO2 and an alkalotic pH. Oxygen levels would be low because of the heart's inability to function properly, therefore that blood flow is not getting to the tissues throughout the body, causing poor perfusion. Obstructive shock patients are not typically intubated and mechanically ventilated for extended periods of time because of the quick treatment of the pericardiocentesis. However, if it should be noted that positive pressure ventilation could negatively impact the venous return. Tension pneumothorax can be a spontaneous or due to trauma. This is the accumulation of air in the pleural space. Patient assessment with this would be rapid shallow breathing, cyanosis, chest pain, a decreased mental status, increased heart rate, distended neck veins, deviation of the trachea away from the affected side. So if you have a tension pneumothorax on your left, you will see that the trachea will deviate to the right. Absent breath sounds and hyperresonant sounds upon percussion on the affected side will also be found. Hemodynamic monitoring is important due to the obstruction of blood flow due to the accumulation of air, which is causing increased pressure on the heart. PCWP and cardiac output as well as blood pressure will be decreased with right heart values being elevated or normal. Other tests used to diagnose with a tension pneumothorax with shock include an echocardiogram, chest x-ray, and ABG. This is a very emergent condition. The first line of treatment will be a needle decompression in the second intercostal space along the midclavicular line. Vasopressors can be given to help restore adequate blood flow, which improve cardiac output and blood pressure. And a tension pneumothorax patient would present in respiratory distress and hypoxemia as indicated by ABG values with decreased CO2 and an increased pH. Again, positive pressure is contraindicated in shock patients because of its negative effect of venous return. However, mechanical ventilation would be instituted upon onset of acute respiratory failure. Pressure control ventilation is the best option to prevent barotrauma and further damage to the lung from occurring. Pulmonary embolisms are caused by blood clots that travel from other parts of the body to the lung, causing blockages in one or more arteries of the lungs. Patient assessment would include chest pain, shortness of breath, cough with bloody sputum, wheezing, cyanosis, weak pulse, and tachycardia. Hemodynamic monitoring would reveal an increase in pulmonary vascular resistance, mean arterial pressure, and CVP. Decreased PCWP, cardiac output, and blood pressure would be noted. Hemodynamic instability is determined by the size of the emboli and underlying cardiac issues. Continuous monitoring is vital to monitor the speed of the resolution of the emboli as the pressures normalize. Anticoagulants such as heparin prevent new clots from forming, and thrombolytics are clot dissolvers. In emergency situations, a PE patient in shock may require surgery to remove the clot if thrombolytics are not resolving the clot quickly enough. Vasopressors may be needed if cardiac output and blood pressure do not normalize in a relatively quick fashion, and supplemental oxygen is needed to improve hypoxemia and decrease work of breathing. This will also help the tissue perfusion as well. An ABG alone cannot confirm the existence of a PE. Obstruction of flow through the pulmonary artery creates a VQ mismatching as the lungs are ventilated but not perfused, creating dead space ventilation. Pulmonary embolism is a form of shunt as indicated by the low oxygen levels, hypoxemia. The patient is oxygen hungry, blowing off too much CO2, and therefore making the blood alkalotic. Let's see, because a PE is an oxygenation problem and not a ventilation problem, intubation and mechanical ventilation is not typically required when treating a pulmonary embolized shock patient. As discussed previously, positive pressure ventilation is contraindicated as it further decreases venous return. And actually, a study was performed on dogs with induced pulmonary emboli that showed that the effects of high-frequency jet ventilation versus the controlled mechanical ventilation, that high-frequency jet ventilation outperformed controlled mechanical ventilation by maintaining both your oxygenation and ventilation when compared to the same pH CO2. So Sarah and I found that pretty interesting. In conclusion, all aspects of obstructive shock require immediate intervention. Commonalities can be found both hemodynamically and pharmacologically. I think that we've pretty much seen in all of our instances of shock that there are a lot of common things that run through those, whether it be the treatment, the causes, and I think a lot of that goes back to its effect on the heart and the heart's ability to perfuse throughout the body. Again, shock is the body's inability to have blood flow throughout the body. So just take care of yourself, do the best that you can, and keep that blood flowing. Thanks.